Hello everyone, this is Dr. Suraj here. Today we'll be talking about thyroid malignancies. So after completing the surgical anatomy of the thyroid gland and various triangles of thyroidectomy, we will be now approaching to various kinds of thyroid malignancies. So before going to the actual discussion, just showing you what are the things that we are going to learn from now. So see these things we are going to learn. So first, we'll be dividing the thyroid malignancies into differentiated thyroid carcinoma and anaplastic carcinoma. Differentiated thyroid carcinoma, that is DTC, and you have anaplastic thyroid carcinoma. Okay, please remember, and this all of them are arising from the follicular cells of thyroid. They are arising from the follicular cells of thyroid. Now differentiated thyroid carcinoma may be papillary thyroid carcinoma, may be follicular thyroid carcinoma, or maybe Hurthle cell carcinoma, and we have anaplastic carcinoma here. Okay, next we'll be having another variety that is not from the follicular cells. It is from the parafollicular C cells of the thyroid gland that produces calcitonin, that is medullary thyroid carcinoma. Okay, and last we'll be discussing about thyroid lymphoma. Now coming into the papillary thyroid carcinoma. Papillary thyroid carcinoma, here we have to remember it is the most common tumor in the iodine sufficient area, whereas in the iodine deficient area the most common tumor is follicular thyroid carcinoma. Please remember, and overall most common is papillary thyroid carcinoma. Papillary thyroid carcinoma is most indolent tumor. Okay, that's why it is having best prognosis. It is having best prognosis, please remember. But there is another variety of papillary thyroid cancer, that is what is known as follicular variety of papillary thyroid cancer. This follicular variant is having not that much good prognosis. It is what is known as Lindsay's tumor. It is what is known as Lindsay's tumor. Okay, that is the follicular variant of the papillary thyroid carcinoma. This is the cancer which is associated with radiation exposure. Okay, and when this papillary thyroid carcinoma is associated with radiation exposure, please remember it is not that much indolent, it becomes aggressive. And in the management also we'll be talking, whenever this papillary thyroid carcinoma is associated with radiation exposure, we are not going to perform hemithyroidectomy, we have to go for total thyroidectomy. Okay, next coming into very important, and this question was asked, that long standing thyroglossal cyst है, then it increases risk of which thyroid malignancy. See, each and every point we are discussing here will be again revising at the end of video, so don't worry. Okay, there will be having rapid fire. So long standing thyroglossal cyst agar hai, then please remember it is going to be papillary thyroid carcinoma. But if they say that long standing goiter, multinodular goiter, that will be your follicular thyroid carcinoma. Okay, side by side we are also discussing follicular thyroid carcinoma here. Now coming into the mutations. Papillary thyroid carcinoma का most common mutation if they ask you is the BRAF mutation or BRAF mutation. Now the other mutations that can happen here is the rate PTC. Now rate PTC 3 may be there, rate PTC 1 may be there. 3 is more number, so rate PTC 3 associated PTC, that is papillary thyroid carcinoma, they are more aggressive, and the PTC which are associated with rate PTC 1, they are less aggressive. So normally this PTC is having best prognosis, but if it is associated with radiation or if it is associated with rate PTC 3, then it becomes aggressive. Understood? So another one is the NTRK1. So you can remember these are the mutation that can happen. And coming into how the patient will be presented to us, the swelling is most common presenting symptom. The patient have the presenting feature will be swelling, but many times what happens, there is something that is known as microcarcinoma. It's having less than 1 centimeter of the diameter, that's why it is non-palpable. Remember, this non-palpable carcinoma is what is known as occult carcinoma, and this occult carcinoma may not be palpable, but in the meantime it might have metastasized to the lymph node, and that is what is known as lateral aberrant thyroid, where the lymph node metastasis occurred from an occult PTC, and here only the lymph node is palpable, but as that is a microcarcinoma from where the metastasis had happened, it is less than 1 centimeter, so the primary tumor is not palpable. So that is what is known as lateral aberrant thyroid. Understood? That is what is known as lateral aberrant thyroid. Now the patient most commonly presented to us with swelling. Okay, the swelling is, please remember, it may be cystic swelling also, and it is multifocal in origin. Okay, now spread, please remember, lymphatic spread is what is most common in papillary thyroid cancer, and please remember, in case of thyroid malignancies, if they are spreading through lymphatic spread is there, the first lymph node that is getting affected is the Delphian lymph node. What is getting affected is Delphian lymph node, which is nothing but level 6 lymph node. Okay, level 6 lymph node. Involvement of the Delphian lymph node is what is N1A. Okay, N1A staging. Okay, I just told you lymphatic spread that is most common happens, and most commonly it is to the level 6 lymph node. Okay, but hematogenous spread may also happen, and that too to the lung, that is to the lungs. Okay, this is most common to the lungs. We'll be discussing and summarizing everything in a box manner. We'll be doing everything there, so please be patient here and understand whatever I am saying now. So how are we going to diagnose it? The patient is presented to us with swelling. So if there is swelling, so we'll be doing FNAC and histopathological examination. Okay, so what are the things in HPE that will guide us that it is PTC, that is papillary thyroid carcinoma? So please remember that papillary thyroid carcinoma means there will be papillae, and this papillae means there will be papillary projections like that, and this papillary projections will be having the fibrovascular core inside. This is first thing that you need to know. See, there is papilla formation, you can see, okay, and inside papilla you have fibrovascular core. You can see this is the papilla formation, and inside the papillae you can see the fibrovascular core here. Okay, next, very important, orphan Annie eye nuclei. Orphan Annie is a cartoon character. Okay, and this description is actually giving that this papilla which are lined by the cells, those cells are having optically clear nucleus. The papillae which are lined by the cells, these cells are having optically clear nuclei. On high power the cell appears empty. Next, you have Samoma body. Next is Samoma body. Now what is Samoma body? It is foci of dystrophic calcification. So Samoma body is foci of dystrophic calcification. Now please remember, this dystrophic calcification is appearing as a black colored bodies when we are staining it with, what is the stain for calcium? Von Kossa. So when we are staining with Von Kossa, that is, or we are staining with alizarin red S. We'll be discussing what are the various conditions where Samoma bodies are seen. Okay, like papillary thyroid carcinoma, papillary variant of renal cell carcinoma. Okay, it is seen in serous cystadenocarcinoma, serous tumors of ovary. We'll be doing that. Okay. Next is coffee bean nuclei. You see this nuclei. The nuclei will be having horizontal groove inside. Okay, see, this is the nuclei, and this nuclei is having horizontal groove inside. That is what is known as nuclear grooving or coffee vein nuclei. Coffee vein nuclei is also seen in Brenner's tumor and granulosa cell tumor of ovary. Okay, next, coming into nuclear pseudo inclusions, that you can also see here that the nucleus is having pseudo inclusions inside. So just you have to remember this three: papilla and orphan Annie nuclei, okay, and Samoma bodies. These three are important. Now you can also see this slide that this is the papilla having fibrovascular core inside, and I just told you this is the optically clear nuclei. These are pseudo inclusions. Okay, these are pseudo inclusion. Nuclear grooving is there. This is the cell having this groove. So nuclear grouping is there, okay, and intranuclear pseudo inclusions. So please remember these 5 features, those are important. Okay. Now coming into the follicular thyroid carcinoma. Follicular thyroid carcinoma is the second most common thyroid malignancy. This is the second most common thyroid malignancy, and it is mostly in the iodine deficient areas. Now this is having the bad prognosis. Papillary thyroid carcinoma is best prognosis. Then you have lengthier variety, that is the follicular variety, and then you will be having follicular thyroid carcinoma. Okay, we will be arranging the thyroid carcinoma according to their prognosis. Okay, later. Now coming into this question, I already told you that multinodular goiter is there for a long time, which thyroid carcinoma will be predisposed in them. This group will be having a high risk for development of the follicular thyroid carcinoma. Already I told you KRAS is the mutation that is associated with follicular thyroid carcinoma. The patient will be presented here with swelling again. Okay, and what we'll be doing again, we'll be doing FNSC of the swelling. Okay, but please remember that follicular thyroid carcinoma mein FNSC is not diagnostic. It is not diagnostic. Why it is not diagnostic? We are just going to see it. Spread, please remember, as I told you, that lymphatic spread, if happens, it will be to the first lymph node, that is the Delphian lymph node or level 6 lymph node. But here for the follicular thyroid carcinoma, okay, the most common route of spread is hematogenous spread, and this hematogenous spread is to the bone. Please remember, it is to the bone. Okay, there will be pulsatile bony metastasis. This metastasis is pulsatile bony metastasis. Can you tell me other condition, other carcinoma where also you will see pulsatile bony metastasis? Yes, very good. This is renal cell carcinoma, where you will also see pulsatile bony metastasis. Now, why this FNSC, which was very much efficient to diagnose all other thyroid carcinomas, not diagnostic in follicular thyroid carcinoma, is this one. Now, this is what are the follicles. You can see these follicles are lined by follicular cells, and inside which you have colloid. Okay, and this is the capsule of the thyroid gland, and this capsule is breached, and there is mushrooming of these follicular cells after breaching the capsule. So this is what is the very important feature of capsular invasion or vascular invasion. Okay, that is very important feature of follicular thyroid carcinoma, and this is why this is having bad prognosis than papillary thyroid carcinoma. Understood? This is important. So there will be capsular invasion or vascular invasion, and that is leading to mushrooming. That is leading to mushrooming of the cells outside the capsule. Okay, so FNSC, as I told you, it is not diagnostic. It is not diagnostic. Okay. What is the criteria for having adequate sample for FNSC? You have to remember this thing. The adequacy of FNSC is a specimen should have 6 groups of follicular cell. So you will be having 6 groups of follicular cell, and each group will be having at least 10 cells. So 6 groups, and each of the groups should have at least 10 cells, preferably on a single slide. Okay, but there are certain exceptions where this 6-10 rule must not be followed, like thyroiditis, where just presence of inflammatory cells or abundant inflammatory cell makes a diagnosis of thyroiditis. Also, thick abundant colloid, if present, it makes the diagnosis of benign colloid nodule. Also, if any numbers of atypia or malignant cells are present, it also makes a diagnosis of atypia or malignancy. There this 6/10 rule is not followed. Okay. Next, now coming into the third variety of differentiated thyroid carcinoma, that is Hurthle cell carcinoma. Please remember, this Hurthle cell carcinoma is having Hurthle cells. So this is not specific. They might also be present in follicular thyroid cancer, or they might be present on adenoma. Okay, they may be seen in Hashimoto's thyroiditis. Okay, also they are seen in thyroid lymphoma. and this is also having high bony metastasis rate. Next is anaplastic thyroid carcinoma, which is least common variety and is also having worst prognosis. So it is least common and having worst prognosis. Now why it is having worst prognosis? Because this is the cancer is going to rapidly progress. So the local invasion is very high, and the local invasion can cause many symptoms before actually the metastasis happens. Okay, the local invasion to the recurrent laryngeal nerve can cause hoarseness of voice. If it involves or if it presses over the trachea, that can lead to stridor. That can lead to stridor, even dyspnea. This is a very hard swelling. This is a very hard swelling because it is a rapidly growing tumor, and this is very hard swelling like a Riddle's thyroiditis. It is a serous carcinoma. Now, distant metastasis is most common, and metastasis is most common to the lungs. Metastasis is most common to the lungs. Okay. Mutation, remember P53 is the mutation that you have to remember from here. Also, it is associated with beta catenin mutation and upregulation of the miRNAs. Which miRNAs are upregulated here? 1792 miRNAs upregulated. This is having worst prognosis because it is rapidly growing. Now, anaplastic thyroid carcinoma, as I told you, it is not considered under the differentiated thyroid carcinoma, but the staging is same as the differentiated thyroid carcinoma. Okay, the staging is same as the differentiated thyroid carcinoma. Discussing the thyroid lymphoma here, thyroid lymphoma is seen most commonly the patients having long-standing Hashimoto's thyroiditis. So the patients who are having long-standing Hashimoto's thyroiditis are prone to develop thyroid lymphoma. The lymphoma is a non-Hodgkin types of lymphoma, either diffuse large B cell lymphoma or small blue cell lymphoma. So these patients will be presented to you with swelling of the thyroid gland with fever, night sweats and weight loss. Okay, here also the diagnosis is made by true cut biopsy. True cut biopsy. Okay, we are not going to do FNAC. True cut biopsy is done in case of lymphoma, the thyroid lymphoma, anaplastic thyroid carcinoma. Probably I did not mention it. Riddle's thyroiditis. Riddle's thyroiditis, it's a fibrosing condition mediated by IgG4. Okay, this is grouped under IgG4 mediated diseases. There is fibrosis, so true cut biopsy is done. Okay, so now we are going to discuss medullary thyroid carcinoma. Let's discuss medullary thyroid carcinoma. As I previously told you that medullary thyroid carcinoma is not arising from the follicular cell. These are arising from the parafollicular C cell, and this parafollicular C cell, they are going to secrete calcitonin. Now that's why this calcitonin becomes very important. It becomes the tumor marker of medullary thyroid cancer. Please remember, if calcitonin is negative, in that case we are going to do CEA, carcinoembryonic antigen assay. Okay, and if the calcitonin level is more than 200 picogram per ml, then we have to go for prophylactic central lymph node dissection. Now these parafollicular C cells, they are developed from neural crest cells. These neural crest cells are nothing but your ultimobranchial body. These neural crest cells developed from the ultimobranchial body. Now supposing sometimes what happens, this calcitonin is normal. This calcitonin tumor marker is normal. Yes, we have to go for CEA. But what we can also do here to increase the calcitonin secretion is what is known as pentagastrin stimulation. We can do pentagastrin stimulation. This pentagastrin stimulation is actually when this pentagastrin, we give pentagastrin to those patients who develop MTC but calcitonin level is normal, then this pentagastrin stimulation will do increase calcitonin. The calcitonin level will be increased. Medullary thyroid carcinoma is associated with Main syndrome. If you want to remember only one thing from medullary thyroid carcinoma, please remember this: medullary thyroid carcinoma is associated with Main syndrome. Actually, medullary thyroid carcinoma may be familial and may be sporadic. Okay, now this familial is most common variety, and whatever syndromic associations I am going to tell you, that is Main syndrome, is associated with familial only. The sporadic is not associated with those things. The Main syndrome, as we know that Main syndrome is having Main 1, Main 2, Main 3, Main 4. Okay, we'll be discussing Main in a separate video. It may be associated with Main 2A, Main 2B. Main 2B is also known as Main 3. Okay, Main 2B or 3, that is what is known as Gorlin syndrome. Main 2A, which is also known as Sippel's syndrome. Main 1 is known as Wermer syndrome. Wermer syndrome, not Werner, it is Wermer syndrome, but that is not associated with medullary thyroid carcinoma. Main 2A and Main 2B or 3 that are associated with medullary thyroid carcinoma. And please remember, if it is associated with Main 2B, that will be much more aggressive. This one will be aggressive. How the patient will be presented to us, there will be typical history that will be provided. Yes, the patient will be having swelling, okay, but more of the patient will be having some other features like diarrhea and flushing. Okay, the diarrhea is because of increase in serotonin. The flushing is because of increase in histamine. Now, the age group that is typically involved is the younger age group, the familial one. Remember the follicular adenoma, where also it is involving the younger age group. Okay, Baki thyroid malignancies are generally seen in adult and post-adult age group. Okay, these tumors are generally multicentric and multifocal, and again there is lymphatic spread. Lymphatic hoga to level 6, I already told you, and hematogenous here will be to the liver. Don't worry, we will be summarizing everything, so just be patient and learn everything here. The histopathology, may if you have to remember only one thing, just remember this one, that this is the malignancy which is associated with amyloid. And which kind of amyloid? The protein is ACAL. Okay, so this is amyloid, which you can appreciate from here. This is the amyloid in the stroma. The amyloid deposition, if they are asking some malignancy of thyroid, please do answer it as medullary thyroid carcinoma. Also, you will be seeing spindle shaped cells, and this amyloid is stained with what? Congo red. Now this Congo red will show you apple green birefringence. Now we are going to discuss few features regarding Main syndrome. So you can remember it in this way, like you can write pituitary, pancreas, parathyroid, then thyroid, pheo and mucosal and marfanoid features. So you can remember this algorithm. Now if there is pituitary, pancreas and parathyroid involvement, that is what is Main 1 syndrome. Main 1 syndrome is having pituitary adenoma, and the most common pituitary adenoma that is seen is prolactinoma. Next, you will be having pancreatic endocrine neoplasia, and this pancreatic endocrine neoplasia, which is most commonly seen in case of Main 1, is gastrinoma, but most common overall is insulinoma. Insulinoma is the most common pancreatic endocrine neoplasia overall, but when it is associated with Main 1 syndrome, it is gastrinoma. Also it is having parathyroid adenoma. So when you see these three, this is your Main 1 syndrome. These are all autosomal dominant, please remember. Next, coming into Main 2, Main 3 syndrome. Now, when you will be seeing last thing, that is thyroid, pheochromo and mucosal marfanoid. Mucosal means mucosal neuroma. Marfanoid features will be there. There will be megacolon, Okay, these are all features are there. And last 3, that means it is 3, third. 3 is also 2b, I have just told you, and this is what is known as Gorlin syndrome. Type 1 is also known as Warmer syndrome. Type 2 is this one, where you will be having parathyroid features, thyroid and pheo. That is what is type 2a. Type 2a is also known as Sippel syndrome. So the thyroid condition that you will see here is what is your medullary thyroid cancer that we have already discussed. This is medullary thyroid cancer in 2b and 2a, and 2b के साथ it is more aggressive. Now main 4 is associated with CDKN1B mutation. Okay, and please remember this is having renal tumors, adrenal tumors. Okay, renal tumors, adrenal tumors, and the testicular tumors will be there along with the pituitary and parathyroid adenomas. Now what they will ask you is the chromosome number from this. This is very important. The main one chromosome number is chromosome number 11. Chromosome number 11. Okay. Main 2 is chromosome number 10. So either 10, 2A, 2B or 3, that is 10. And this gene is your red proto-oncogene. You remember red proto-oncogene mutation in chromosome 10 that led to your medullary thyroid carcinoma. Okay. So and main 4 is chromosome number 12. Chromosome number 12 में CDKN1B is the mutation. Now this is the proper time to discuss the surgical approach to each and every thyroid carcinoma that till now we have discussed. Okay, so we'll be first starting with the papillary thyroid carcinoma, which is the most common thyroid carcinoma overall, having best prognosis. We have done FNAC, and FNAC is showing these features, so we have diagnosed it as papillary thyroid carcinoma. Now papillary thyroid carcinoma will be doing surgery, so we'll be performing hemithyroidectomy. Hemithyroidectomy is done only when the size of the tumor is 1 to 4 centimeter. That means within 4 centimeter we'll be performing hemithyroidectomy. Okay. Now recently they have said that less than 55 years of age is if the thyroid carcinoma is appearing less than 55 years of age, then it will be having good prognosis. Okay, and if it is more than 55, then it will be having a bad prognosis. So now coming back here, that size 1 to 4 centimeter, unifocal, and there is no lymphovascular invasion or no distant metastasis. If all these criteria are present, then we are going to perform hemithyroidectomy. But if there are other patients, like the size of the tumor is more than 4 centimeter, more than 4 centimeter means it's a T3 tumor. T3 tumor is your T3A, T3B. Okay, T3A means the tumor size is more than 4 centimeter and it is restricted within the thyroid gland. It is restricted within the thyroid gland, that is T3A. T3B is any tumor which is just restricted within the strap muscles, that sternothyroid, sternohyoid, these strap muscles. So this will be T3B. Extrathyroidal, that is involving other than the strap muscle, is what is T4. If this is T3, T4, then we have to perform total thyroidectomy. We cannot go for hemithyroidectomy. If there is radiation exposure, that is radiation induced, I already told you that is aggressive variety, then also you have to go for total thyroidectomy. If it is multifocal, not unifocal, then it is again total thyroidectomy or extrathyroid extension, as I mentioned in T4, extrathyroid or T3B, extrathyroid extension, then also total thyroidectomy have to be done. Now level 6 lymph node, as I told you, it is the fast draining lymph node of thyroid carcinoma. Now please do remember, if level 6 lymph node is present, that is what is N1A staging, and in that case also you have to go for total thyroidectomy plus central neck dissection. Central neck dissection means here you are removing level 6 plus minus level 7 also, because recently level 6 is in the in 1A group. In 1A staging में level 6 as well as level 7, these two are incorporated. So if level 6 is involved, then total thyroidectomy plus central neck dissection has to be done. But if other groups are involved, like level 1, 2, 3, 4, 5 में से, then you have to do modified radical central modified radical neck dissection, MRND. So you do total thyroidectomy for the thyroid and central neck dissection for N1A as well as for N1B, that means the other lymph nodes are involved. Modified radical neck dissection, this may be unilateral or maybe bilateral. Okay, as I already told you, if it is a T3 T4, so you have to do prophylactic central neck dissection you have to do along with total thyroidectomy. So prophylactic central neck dissection has to be done. Also, I told you that if the calcitonin level is more than 200 picogram per ml in medullary thyroid carcinoma, you have to do prophylactic central neck dissection. Now, after the surgery, we have to know whether any residual disease has been left or any metastasis is present. For that, we are doing whole body iodine scan. This is to know whether any residual disease is left or any metastasis present or not. Okay. Now, how to know whether residual disease is left or metastasis present or not? We are giving iodine. Now, thyroid gland, if I can make the thyroid gland hungry, so it will take up the iodine. How can we make that? So the prerequisite for this whole body iodine scan, that the TSH should be more than 20 international unit per liter. And how we can make this? Either I can give TSH, so I can increase the TSH level so the TSH will shoot up from a normal value to more than 20, or what I can do is I can decrease the T3 T4, the intake of thyroxine. So there will be a thyroxine free interval for 4 to 6 weeks after surgery, and as a result that negative feedback will be withdrawn and the TSH will be secreted from the pituitary. So by any of this we can reach the prerequisite. When we are not giving thyroxine for 4 to 6 weeks, that is what is conventional method, but that is time consuming. You have to wait for 4 to 6 weeks to actually know whether there is any residual disease or metastasis, and in this meantime anything can happen. So what is better is increasing TSH. So TSH can be given 2 injections of TSH in 2 days. Just you can give 2 injections. So if the patient does not have time, then we can recommend them this TSH injections. Okay, the 2 injections for 2 days, and they are costly. And very important, here we are not giving thyroxine in conventional method, so patient can land up in hypothyroidism. With TSH injection, hypothyroidism is not going to happen. But what are the side effects of this whole body iodine scan? Remember, sialadenitis, nasolacrimal duct obstruction. Also, it can lead to infertility. Also, it increases risk of other secondary carcinomas. So these are the side effects of whole body iodine scan. So till now, after surgery, we have done whole body iodine scan to know the residual disease or metastasis present or not. Now suppose the residual disease or metastasis is present, then what we are going to do? We are going to do radioiodine ablation. Radioiodine ablation. Now this radioiodine ablation, very important. This radioiodine ablation uses iodine 131 isotope, and the T half, it uses the beta rays, and the T half is around 7 to 8 days. Around 7 to 8 days. Okay. Now there are certain conditions also you have to remember where the residual disease is absent, but still we used to give radioiodine ablation, and that is a single shot or single dose of radioiodine ablation. Okay, the patient who has no residual disease or no metastasis but having lymph node positive. So there is lymph node positive, or there is extrathyroidal involvement, or there is extrathyroidal spread. In this condition, single dose radioiodine ablation. Okay. Also, we'll be studying another condition, that where in spite of treating the patient, the tumor marker for differentiated thyroid carcinoma, that is serum thyroglobulin, that is still increased, that the level is persistently high even after treatment. In this condition also, we are going to give single dose radioiodine ablation. Now, if the residual disease or metastasis is absent, in that case what we are going to do is TSH suppression test. See, TSH suppression is done by giving thyroxine. Okay, so we give thyroxine, and thyroxine is going to inhibit the pituitary, like negative feedback to the pituitary, so the TSH secretion will be decreased. Okay, TSH is a potential factor which can increase the growth of the gland. Okay, so what happens, this TSH suppression is needed to prevent the growth of the tumor or prevent the growth of the cancer, further recurrence. To prevent that, we are doing TSH suppression, and this TSH suppression can lead to hypothyroidism. Okay, that's why we are suppressing this TSH by giving thyroxine. So it is to prevent the hypothyroidism. And then we have to follow the patient. Follow up of the patient is done using two things. One is we'll be doing USG neck for 6 months interval, and next thing we will be assessing is the serum thyroglobulin. The serum thyroglobulin is what is the tumor marker for all the differentiated thyroid carcinoma. For all the differentiated thyroid carcinoma, is the tumor marker is serum thyroglobulin. For the medullary thyroid carcinoma, C cell calcitonin, so CEA and calcitonin, these are the two carcinoma, these are the two tumor marker for medullary thyroid carcinoma. USG neck and serum thyroglobulin के साथ we will be doing the follow-up. So during that, if the serum thyroglobulin level becomes more than 2 nanogram per ml, in that case it is what is called as recurrence. Now this recurrence is treated by again doing whole body iodine scan. Okay, whole body iodine scan. We can also do PET scan to know recurrence, but PET scan is never done in the primary scenario of thyroid carcinoma. Okay, if it's a recurrence one, then only we can do that. Okay, another thing you have to remember from serum thyroglobulin, that supposing the patient is having antibodies against this serum thyroglobulin, that is anti-thyroglobulin antibody, then if you assess this serum thyroglobulin, it will of no value because it is giving false negative or false low value. So for that, prior antibody panel testing, that is all the anti-thyroid antibody panel testing has to be done to look for whether any anti-thyroglobulin antibodies are present or not. Okay, if the patient is having Hashimoto's thyroiditis, you have to do this. Next is, suppose the patient is resistant to radioiodine ablation, what will we do? So here we are left with something that is known as external beam radiotherapy. Also we can go for chemotherapy using doxorubicin. And third one, we can treat those patients, the resistant cases, with sorafenib and leventinib. So these are the things available in resistant cases. Next, coming into the follicular thyroid carcinoma. So follicular thyroid carcinoma mein we have done FNAC, and FNAC is inconclusive, and that is actually giving you this report like follicular neoplasm. So you have to be very much sure whether it is a follicular thyroid carcinoma or follicular adenoma. You have sent FNAC sample to the pathologist, and the follicular neoplasm is the report that she is sending. Now follicular neoplasm is the report. Whenever follicular neoplasm is there, you have to perform hemithyroidectomy. Now, whatever thyroid you have removed during operation, that is intraoperatively, you have to send that specimen to the pathologist intraoperatively for frozen section. The pathologist will tell you within 30 minutes whether there is follicular carcinoma or adenoma. So what is the feature that is differentiating this follicular carcinoma and adenoma? We have already discussed, that is the capsular breach or the vascular invasion and mushrooming. These things are actually the pathologist is looking for these things. If these are present, so he or she will report it as follicular carcinoma. Now once it is diagnosed as follicular carcinoma, the surgeon is waiting on the OT table, so he or she will perform the same thing as papillary. Once the follicular carcinoma report is there, then the same thing will be followed like that of papillary thyroid carcinoma. But if it is follicular adenoma, we have already done hemithyroidectomy, nothing is needed here. Next, coming into anaplastic thyroid carcinoma, this is very easy. As I told you, it is the most aggressive tumor, not only in the thyroid gland, but it is the most aggressive tumor of the body. Okay, if the patient is having this, hardly he or she can survive for 6 to 8 months. It's the most aggressive cancer over all the body. Okay, so as this is most aggressive, the treatment, the surgery will also be that much aggressive surgery. The staging of this anaplastic is same as that of differentiated. Now you are doing FNAC, but FNAC is not that much conclusive here. So TrueCut biopsy is done, and I already told you TrueCut is done in case of lymphoma, thyroid and anaplastic thyroid carcinoma and Riddle's thyroiditis. So TrueCut biopsy is done, and then it is showing it the growth is restricted to the thyroid or there is extrathyroidal involvement. So if it is restricted to thyroid, even it is restricted, we have to go for aggressive management. So we will be doing total thyroidectomy plus central neck dissection plus minus depending on we can go for MRND. Okay, whether it is needed or not, we can go for MRND also. So even it is restricted, we have to go for aggressive surgery. And if there is extrathyroidal involvement, so we have to go for palliative treatment. This palliative treatment is done either by chemotherapy or we can use some antibodies like dabrafenib. Okay, that is antibody against tyrosine kinase inhibitor BRAF mutation. As it is very aggressive, so before going to metastasize, it can present with local symptoms. So if the local symptoms are present, then to relieve the symptom, we can perform isthmusectomy to relieve the pressure. And next, coming into medullary thyroid carcinoma. So radioiodine ablation is not going to help. Okay, radioiodine ablation is not going to help here because it is not from the follicular cell, it is the parafollicular cell. Here the surgery will be one step ahead of what we have learned. Okay, so if it is only restricted to the thyroid gland, one step ahead, that is total thyroidectomy, but here we will be doing central neck dissection. Okay, and if there is any lymph node, either it is level 6 or other lymph node, we have to go for total thyroidectomy plus central neck dissection plus MRND. This is one step ahead. There in papillary, I just told you level 6 is there, then we have to go for central neck dissection, but here one step ahead MRND is done. And papillary mein other lymph node involved, so we have to do MRND. Here also we are doing MRND. Okay, because we cannot go one step ahead MRND. If it is metastatic tumor, then what we can do? Then obviously a debulking surgery has its role. Debulking should be done because it improves the survival of medullary thyroid carcinoma, survival of the patient. And again, the patient has to be put on tyrosine kinase inhibitors like vandetanib and cabozantinib. Okay. Now there is a condition, I told you that this medullary thyroid carcinoma is associated with Main syndrome. Okay, and one of them is pheochromocytoma, that is mostly associated with type 2B or 3. So if that is a condition where the patient is having medullary thyroid carcinoma and pheochromocytoma, Always treat the pheochromocytoma first and then go for medullary thyroid carcinoma management. As I also told you, this parathyroid gland is involved. Okay, parathyroid adenoma is there because it is associated with main syndrome. So hyperparathyroidism and MTC, if there, then you can simultaneously manage both. Thyroid lymphoma, again thyroid lymphoma mein we are doing TrueCut biopsy. After that we are diagnosing thyroid lymphoma, and then we are starting the chemotherapy regime, that is R-CHOP regime. The R-CHOP regime is rituximab, which is CD20 inhibitor, then cyclophosphamide hydroxydonorubicin, O for oncovin and vincristin, and P for prednisolone. This is the chemotherapy regime that should be followed by the radiotherapy. And even after that, if this is recurring or residual disease is present, we have to go for surgery. So everything regarding this is discussed now. So now the time came. Let's answer few of the questions. Most common primary thyroid malignancy, I told you it is papillary thyroid carcinoma. Okay. Next is most common thyroid malignancy associated with radiation. I told you papillary thyroid carcinoma mostly associated with radiation, and when it is associated with radiation, it is aggressive. Okay. Also told you that rate PTC3 is more aggressive. Remember, most common malignancy of thyroid associated with lymphatic spread. Now, lymphatic spread is associated with papillary thyroid carcinoma. I mentioned lymphatic spread is most common in papillary, Delphian lymph node. Rest all are mostly through the hematogenous route. Most common thyroid malignancy associated with bone and blood metastasis as follicular carcinoma. Okay, please remember follicular where you see pulsatile bony metastasis. You remember pulsatile bony metastasis is also seen in renal cell carcinoma. Understood? Bone metastasis is also seen in Hurthle cell carcinoma. Iodine sufficient area में papillary thyroid carcinoma. Iodine deficient is follicular carcinoma. Most common thyroid malignancy associated with multinodular goiter. I told you it is follicular thyroid carcinoma. Amyloid लिखा है तो always answer it as medullary thyroid carcinoma. Main 2 syndrome, again medullary thyroid carcinoma. We have discussed all these things. Now, most aggressive thyroid malignancy with worst prognosis is anaplastic thyroid carcinoma. Thyroid malignancy with best prognosis is papillary thyroid carcinoma. Okay. Next, orphan anenuclei. It is seen in papillary thyroid carcinoma. Very good. Next is pentagastrin stimulation. Did you remember pentagastrin stimulation? If calcitonin is negative, we can stimulate by giving pentagastrin. The calcitonin level starts increasing. That is done in medullary thyroid carcinoma. Okay. Most aggressive medullary thyroid carcinoma is associated with main 2B. Yes, main 2B. Main 2B is also known as main 3, which is also known as Gorlin syndrome. Very good. Pulsatile bony metastasis, I told you it is follicular thyroid carcinoma, as well as you can remember renal cell carcinoma. Tumor marker for differentiated thyroid cancer, I told you differentiated thyroid cancer में serum thyroglobulin is used as a tumor marker. But for medullary thyroid cancer, what we use is what? Calcitonin parafollicular C cell. So it will be calcitonin. Good. यंगर एज में कौन सा थायराइड कैंसर होता है? प्लीज रिमेंबर इट इज द फैमिलियल वेरिएंट ऑफ मेडुलरी थायराइड कार्सिनोमा. ऑल्सो follicular adenoma is another condition. Next, TrueCut biopsy is done in, I told you TrueCut biopsy is done in anaplastic thyroid carcinoma, as well as it is done in case of thyroid lymphoma and Riddle's thyroiditis. The fast draining lymph node in thyroid malignancy, I told you it is the level 6, which is also known as Delphian lymph node. The Chernobyl nuclear blast associated with papillary thyroid carcinoma because it is the radiation exposure associated cancer. Long-standing thyroglossal cyst, papillary thyroid carcinoma. Multinodular goiter, follicular thyroid carcinoma. Hashimoto's thyroiditis. Okay, you can remember Hashimoto's में अगर thyroid cancer पूछा तो it is papillary thyroid carcinoma, but mostly the lymphoma is the answer. Frozen section is done in whether it is done when the FNAC is inconclusive and we are doing for follicular thyroid neoplasm to know whether it is a carcinoma or adenoma. No role of iodine scan and iodine radioiodine ablation. If it is not arising from the follicular cell, then it is the parafollicular one where I cannot use iodine. So that is medullary thyroid cancer. Now discussing the most common site for distant metastasis. As we know that papillary thyroid cancer is mostly by the lymphatic spread to the Delphian lymph node or level 6 lymph node. But hematogenous route is to lungs. Hematogenous spread is to the lungs. Follicular thyroid cancer and Hurthle cell cancer, their distant metastasis to bones. Anaplastic variety hematogenous spread to the liver, very important. Okay, and medullary thyroid cancer is again to the lungs. So this is what you have to remember. Coming into the prognostic sequence of the thyroid malignancy, the best prognosis with the papillary thyroid cancer and then followed by follicular thyroid cancer. Now in between them there is a follicular variant of papillary thyroid cancer, that is what is known as Lindsay tumor, that is having the prognosis in between them. Next we have Hurthle cell carcinoma. Next you have Hurthle cell carcinoma, followed by you have medullary thyroid carcinoma and anaplastic carcinoma. Anaplastic, I told you, it is having worst prognosis overall. This is what is the prognostic sequence. Last question is what are the conditions where we will get the Samoma bodies. So Samoma body, this is seen in papillary thyroid cancer as well as papillary variant of renal cell carcinoma, serous cyst adenocarcinoma ovary and serous tumor of pancreas. Also it is seen in meningioma, mesothelioma and prolactinoma. Please remember these two, papillary thyroid cancer and papillary variant of renal cell carcinoma and serous cyst adenocarcinoma of ovary. What is this Samoma body? This is nothing but the foci of dystrophic calcification. So what are the stains of calcium? We have already discussed. One is known as von Cossa stain, another is alizarin red S. Okay, so this is what we have learned today. So many facts and so many things we have learned. Please revise. Thank you all of you. See you in the next episode.